Good morning, all. It's the Division of Nephrology's turn to present, and we welcome Dr. Rajoo, our new fellow, and she's going to talk to us about pregnancy, kidneys and your pregnancy, pregnant kidneys, all sorts of things about kidneys and pregnancy. Enjoy. Enjoy everything.
Okay, so the case is a 21-year-old patient. She is a transplant recipient in 2011. She received a kidney at 10 years old when she was in the care of pediatrics. The initial cause of her kidney failure was not known. She developed diabetes post-transplant and severe iron deficiency anemia, which was worked up as a child and was deemed secondary to menorrhagia. We saw her at transplant clinic. She's been following up with adult nephrology for the last couple of years. And at transplant clinic on 16th of January this year, she was seen and noted to have already established graft dysfunction for well over 1 year, fluctuating tacrolimus levels and subnephrotic proteinuria. It was at this visit that she requested contraception, and so Depo-Provera was prescribed. Unfortunately, at this point, she was on a combination of CellCept, tacrolimus, and prednisone for her maintenance immunosuppression. We reviewed her blood results following that clinic and noted that her renal function in January was slightly worse, as well as having labile tacrolimus levels. We offered the patient admission, and she was admitted on the 2nd of February to optimize the drug levels and work her up for this renal dysfunction. It was at this point that we discovered that she was 29 weeks pregnant by late ultrasound. Patient remained in hospital until delivery. We stopped her CellCept at the point of admission. She was noted to be very iron deficient, so she received iron infusions as well as a blood transfusion prior to delivery. The sonar also reported a physiological hydronephrosis of the secondary to the gravid uterus, as well as her proteinuria and renal function continued to worsen until delivery. We booked her for an emergency cesarean section due to worsening preeclampsia, and a live baby girl was born. But unfortunately for the patient, her graft continued to fail, and she still remains heavily proteinuric with declining GFR. So this is just a table with her latest blood results. You can see in September last year, she was pregnant, but we didn't know that. Creatinine was 174, which was comparable to her creatinine in 2022. Continued to worsen throughout the pregnancy. She had at its peak almost 15 grams of proteinuria. And her last blood results at the clinic 2 weeks ago, she's now progressed to end-stage kidney failure. Okay, so the physiological adaptations in pregnancy are quite dynamic. It encompasses a lot of physiological, hemodynamic changes, tubular changes, immunological changes, and then of course the anatomical changes of hydronephrosis. So in terms of the hemodynamic changes, the cardiac output will increase by up to 40%. The blood pressure should drop by 30%, reaching a nadir at around 20 weeks gestation due to the decreased vascular resistance. The vascular resistance is decreased due to interplay between vasodilatory responses and vasoconstrictors. So the vasodilation is mediated by nitric oxide production and relaxin during pregnancy, and also resistance to the RAS activation. Although RAS activation is upregulated due to increased production from the ovaries and the decidua, there is resistance to angiotensin II favoring a vasodilatory response. There's also an increase in the plasma volume, which increases by 50%. This is due to the effects of aldosterone from week 8 of pregnancy up until the 3rd trimester. There's also an increase in ADH secretion, causing hemodilution, with sodium dropping to 130 to 135 millimoles in normal pregnancy. So due to the increased plasma volume, there's increased GFR, which increases by 50%. Also vasodilation of both the efferent and afferent arterioles, secondary to the relaxin and progesterone effects in pregnancy. Despite the vasodilation of the efferent and afferent arterioles, there's still hypofiltration, which results in a physiological drop of creatinine sitting around between 40 to 50 micromoles per liter in normal pregnancy. The hypofiltration also increases proteinuria, which normally increases up to 250 milligrams per day in pregnancy. So the cutoff for an abnormal proteinuria in pregnancy is more than 300 milligrams per day. And the timing of this is important. So prior to 20 weeks, of pregnancy, one must consider pre-existing renal disease or primary renal disease, whereas after 20 weeks, you can consider preeclampsia and hypertensive disorders of pregnancy. This is a a graph taken from a large Canadian study of over 250,000 women in normal pregnancy, showing the changes that are expected during pregnancy. Figure A is looking at the mean serum creatinine concentration, and as you can see, it drops within week 20 to 25 of pregnancy. This drop in creatinine makes using creatinine-based GFR equations quite difficult to interpret, as they usually depend on a steady state of creatinine production. Also, the MDRD formula, which we often use to estimate renal function, is fairly inaccurate for a GFR of more than 60, which is very common in pregnancy. So the trend is more important than the actual value. Okay. There are other tubular changes that occur in pregnancy, including glycosuria despite normal glycemia, and this is because of decreased tubular absorption capacity. Also increased uric acid excretion and bicarbonuria. There are many endocrine changes that occur during pregnancy, but the important ones for renal physiology include erythropoietin production, which increases, but physiological anemia still ensues due to the increase in plasma volume. And then the immunological changes that occur are relevant for the behavior of autoimmune diseases during pregnancy. So the adaptive immune system changes from a shift in Th1 phenotype or cell-mediated immunity to a Th2 phenotype or humoral-mediated immunity, probably mediated by the increase in estrogen during pregnancy. This is necessary to facilitate tolerance to the fetal antigens, trophoblastic invasion, and placental development, as well as increase in Treg production, which also facilitates tolerance. So for example, in lupus, the Th2 phenotype and the dysregulation in the Treg function predisposes to lupus flares, preeclampsia, and other poor pregnancy outcomes. And then the anatomical changes, the kidney increases in size by about 30%, as well as increase in the actual nephron size due to nephron hypertrophy. Physiological hydronephrosis is fairly common, affecting about 80% of pregnancies, and usually develops by the end of the second trimester due to mechanical compression of the ureters against the iliac vessels and ovarian ligaments. It should resolve within a few weeks post-delivery. So there's quite a lot of disorders that can affect the kidneys during pregnancy. It's not going to be feasible to go through all of them. So I'm going to focus mostly on the hypertensive disorders, as well as a bit on transplant and pregnancy. Importantly, all of these conditions can present as acute kidney injury during pregnancy, as well as worsen pre-existing kidney disease like it did in our patient. So the hypertensive disorders of pregnancy are fairly common, affecting between 6 to 8% of pregnancies, and they're among the most prevalent direct cause of maternal mortality in South Africa. This is a schematic of the major hypertensive disorders. So various societies, including NICE, the ISSHP, FIGO, and the American College of Obstetricians and Gynecology, defined the main categories of hypertensive disorders in pregnancy, which include chronic hypertension, where there's a known hypertensive history prior to the onset of pregnancy, or elevated blood pressures before 20 weeks of gestation. You can also get superimposed preeclampsia or eclampsia on a background of hypertension, and as well as gestational hypertension, where there's new onset hypertension on a previously normotensive patient. So in terms of pregnancy and hypertension, the risk factors for any of the hypertensive disorders include an advanced maternal age, obesity, and a Black ethnicity. It's very important to exclude secondary causes of hypertension in these patients where appropriate. Gestational hypertension is defined as a blood pressure more than 150/90 millimeters of mercury, which arises after 20 weeks of gestation with no features of preeclampsia. It should return within normal range after 6 weeks to 12 weeks postpartum. Has a prevalence of about 6 to 7% in pregnancy, and generally arises in the late third trimester. The risk factors include a nulliparous woman, previous history of preeclampsia or gestational hypertension in previous pregnancies, family history of hypertension, obesity, type 2 diabetes, polycystic ovarian syndrome, and multifetal gestation. Complications of gestational hypertension include a preterm delivery and low birth weight, as well as itself being a risk factor for preeclampsia, where 10 to 50% go on to develop it. in terms of the patients you should consider at high risk for developing preeclampsia on a background of gestational hypertension, it's earlier onset of hypertension before 34 weeks, elevated uric acid, evidence of abnormal uterine arteries on Dopplers, and very severe hypertension. So in terms of managing these patients, the antenatal care goal is based around trying to delay progression to more severe complications and to optimize the birth for both the mother and the child. The optimized blood pressure targets should be about 135 to 85, 135 over 85, and also to screen and manage preeclampsia early. So this is done by screening for proteinuria on a monthly basis at least. If available, you can also consider advanced testing with placenta growth factor. And in the patients at high risk, which would include all hypertensive patients, consider starting them on low-dose aspirin from at least 12 weeks gestation. Don't forget to reinforce diet and lifestyle modification where appropriate. In the mild to moderate hypertension range, antihypertensives have been shown to reduce developing severe hypertension by up to 50%. The CHAPTER trial looked at treating mild hypertension in pregnancy with primary outcomes of severe preeclampsia, preterm delivery, a ruptured placenta, and fetal death lower in the treatment arm. So now guidelines have changed to recommend treating at a threshold of 140 over 90. In severe hypertension, it's considered a medical emergency and requires prompt blood pressure control to prevent deleterious consequences to the mother and the child. So you should initiate acute treatment once the blood pressure is reached or beyond this threshold of 160 over 110. The aim is to gradually lower the blood pressure to a systolic of 130 to 150. This is done to ensure that the blood flow to the fetus isn't compromised. Ideally, they should be managed in a high care or high acuity setting for frequent blood pressure monitoring and monitoring the maternal and fetal outcomes, as well as fetal heart rate. So the pharmacology options include IV labetalol and IV hydralazine in combination with immediate release oral nifedipine. You might need a combination of these drugs with multiple dosing to achieve sustained blood pressure control. So uncontrolled blood pressure carries the risk for maternal hemorrhagic stroke, obviously, and then the consideration was tight blood pressure control may have historically been linked to placental hyperperfusion and fetal compromise. So the CHIPS trial was done where tight blood pressure control was targeted, where tight blood pressure control was compared to less tight blood pressure control. In the tight control group, blood pressure was targeted to a diastolic blood pressure of 85, and in the less tight group was targeted to 100. In this trial, they showed that tight blood pressure control during pregnancy decreased the risk of developing maternal severe hypertension without increasing the risk of fetal loss or risk. This is a table showing the drugs that are deemed safe to use for hypertensive control in pregnancy. So methyl-dopa is a first-line agent. It has a well-documented safety profile in pregnancy, but should be cautioned in liver disease. Calcium channel blockers are generally safe in pregnancy, with nifedipine and amlodipine having no contraindications. In terms of the beta blockers, labetalol, selected alpha-1 and non-selected beta-1 blocker, considered quite safe. Carvedilol and bisoprolol also have minimal risk. Atenolol should be cautioned because of its association with intrauterine growth restriction and neonatal hypoglycemia. Not on this table, though, you can also consider alpha blockers, which are safe, as well as hydralazine. The ones that we need to avoid for sure include the ACE inhibitors and the angiotensin receptor blockers, which are teratogenic, causing renal dysgenesis, neonatal renal failure, and fetal loss. Mineralocorticoid antagonists such as spironolactone are anti-androgenic, which can cause fetal feminization. Diuretics also pose a theoretical risk of compromising the plasma volume and are associated with intrauterine growth restriction. In terms of the postpartum period, small amounts of the antihypertensive drugs can pass into the breast milk, but this is likely to be low enough to avoid any clinical effects in the child. The drug choice does depend on the comorbidities. For example, if using an ACE inhibitor post-delivery, it is safe in breastfeeding, but you need to consider potassium and renal function monitoring closely. Consider switching out the methyl-dopa because of the risk of postpartum depression, and consider tapering the doses of diuretics as there's a theoretical risk of milk supply reduction. Okay, so preeclampsia is defined also with an elevated blood pressure of 140 over 90 in a previously normotensive individual on 2 occasions 4 hours apart after 20 weeks. It does usually occur in the presence of proteinuria, but it's not necessary for the diagnosis if there are other features of severity, including thrombocytopenia and AKI, elevated transaminases, neurological symptoms, pulmonary edema, or evidence of uteroplacental insufficiency. So it's a multi-system disorder with heterogeneous mechanisms and phenotypes associated with hyperuricemia and edema. It's a major cause of maternal mortality and morbidity in both developed and developing countries, complicating up to 5% of pregnancies. The risk factors for preeclampsia generally all increase susceptibility to endothelial dysfunction and increase the responsiveness to the anti-angiogenic factors. They include nulliparity, multi-piece gestation, an elderly woman, which is defined as over 40 years old, BMI of more than 35, previous preeclampsia, use of artificial reproductive technology, and then importantly, chronic hypertension increases the risk of preeclampsia by 5-fold. CKD increases the risk of preeclampsia by 10-fold. Diabetes and other autoimmune diseases are also high risk of preeclampsia due to the underlying endothelial dysfunction. So these are the clinical features that we should all know about. The severity and onset of clinical features of preeclampsia are often unpredictable. The major pathophysiological abnormality is abnormal placentation or placental implantation, which leads to hyperperfusion and ischemia of the placenta, yet development of syncytial knots and fibrin deposits in the placenta. In the normal pregnancy, the cytotrophoblastic cells, which are of fetal origin, should penetrate the uterine decidua via anchoring villi. This is facilitated by the remodeling of the terminal spiral arteries in the uterus, which transform into a high-capacity, low-resistance system. And this enables adequate uteroplacental perfusion. In preeclampsia, this doesn't occur. So there's failure of endovascular invasion of the cytotrophoblast because of defective remodeling of the uterine spiral articles. You end up with a high-resistant system resulting in placental hypoxia, causing oxidative stress within the placenta and impairs villus angiogenesis. The hypoxic placenta then produces anti-angiogenic factors, so sFlt1 or soluble FMS-like tyrosine kinase 1 and soluble endoglin are upregulated. So sFlt1 is a circulating antagonist to vasoactive vascular endothelial growth factor and placental growth factor. So it mops up these pro-angiogenic growth factors and leads to an imbalance of anti-angiogenic versus pro-angiogenic factors, leading to endothelial dysfunction, impaired angiogenesis, and inflammation. So if you look at the mom, in terms of the endothelial beds that are typically affected, it's the brain, which manifests as seizures and eclampsia, the liver, which can manifest as HELLP syndrome, and in the kidney, you can get glomerular endotheliosis and proteinuria. This is a diagram showing the imbalance between the pro-angiogenic and the anti-angiogenic factors, which you can use if available to predict early before 34 weeks. So in terms of the diagnosis, screening for preeclampsia has the greatest impact on clinical outcome, but there is a lack of screening tools available. You can look at the uric acid, which is believed to be elevated as a predictor of preeclampsia. They increased sFlt1 and S-Eng in comparison to the decreased placental growth factor can also be used if available, and it's currently included in the NICE guidelines. I don't think it's available to us. In terms of the clinical features, it's new onset worsening hypertension in a previously normotensive individual, evidence of new onset of worsening proteinuria, and then looking at the features of end organ damage. Don't forget to look at the uterine arteries to look for abnormal Doppler velocities. In terms of the management, in the patients that are high risk, which would include your patients with CKD or hypertension, it's low dose aspirin from the first trimester as early as 12 to 14 weeks. And it's been shown by 2 large meta-analyses to prevent preeclampsia and preterm delivery before 34 weeks. You should continue the aspirin until delivery. There's also some benefit, but less evidence for calcium supplementation. And now metformin has also been shown to have benefit in reducing preeclampsia by up to 76%. It does this by reducing the anti-angiogenic factors and improving endothelial dysfunction. A multidisciplinary team should be involved, including obstetricians and obstetric physicians, as well as nephrologists. And the target would be blood pressure management to a target of under 135/85. Again, using the same antihypertensive we discussed previously. Magnesium sulfate also has a role. It's a drug of choice for preventing and treating preeclampsia. It halves the risk of eclampsia, and as well as treating seizures, and has neuroprotective effects on the fetus. It also reduces maternal mortality. And the indications of eclampsia, preeclampsia with irritability signs, or severe preeclampsia with imminent eclampsia. Delivery is the definitive management and is required in most cases. It should result in the resolution of the preeclampsia, which can take up to 3 months postpartum to completely resolve. In milder preeclampsia or preterm patients, you can consider expected management with the goal of trying to push the pregnancy to 37 weeks, but it requires close monitoring and admission until delivery. Again, tight blood pressure control targeting under 135/85, and also managing the VTE risk. So VTE risk is especially high in the proteinuric patient, and they should all be considered for thromboprophylaxis, either mechanical or pharmacological with low molecular weight heparin. These are the risk factors in patients that for preeclampsia that should be initiated on low-dose aspirin. In terms of magnesium sulfate, there are some toxicities that you need to be aware of. Most importantly, confusion, and the neurological ones, including confusion and areflexia, as well as circulatory collapse and respiratory depression. Remember, magnesium is renally excreted, so you should caution it if the urine output tapers to less than 20 mL per hour. In terms of the complications, we spoke about the VTE risk acutely. Low molecular weight heparin and mechanical prophylaxis should be considered in high-risk individuals for up to 2 weeks post-delivery. Pulmonary edema is an acute complication, and infusion of large volumes of IV fluid should be avoided in these patients. Generally, diuretics are not recommended unless there's significant pulmonary or pedal edema, and strict input-output monitoring is required. In terms of the long-term effects of preeclampsia, it does predispose these patients to late cardiac and vascular diseases such as stroke, ischemic heart disease, and hypertension, as well as increasing the risk of chronic kidney disease. Specifically at the kidney, what happens in preeclampsia is that the GFR and the renal plasma flow decrease by 30 to 40%, which is very different compared to what's expected in normal pregnancy. It puts these patients at risk of hypoperfusion and ATN. And they also get a lesion of glomerular endotheliosis, which is a pathognomonic for preeclampsia. It's characterized by swollen endothelial cells and mesangial cells on biopsy, and as well as what you'll find on biopsy is very akin to FSGS changes within large bloodless glomeruli and obliterated capillaries. The high soluble FLT1 levels inhibit podocyte-specific VEGF, and this results in the formation of these fenestrae, which contribute to the proteinuria seen in the pregnancy. So the slit diaphragm proteins, which are important for us, nephrin and podocin, as well as synaptopodin in the podocyte, are damaged because of the lack of VEGF. So podocyte damage contributes to the proteinuria. It should resolve by 8 weeks postpartum. Other sort of hypertensive disorders that you need to be aware of during pregnancy include HELLP syndrome, which is seen in about 1 to 2% of preeclamptic patients. And with regards to HELLP, again, is managed in a very similar way with a multidisciplinary team. Delivery is the definitive treatment and should be considered if the gestation age is more than 34 weeks. And then eclampsia. So eclampsia is a very uncommon condition associated with a very high mortality and morbidity, secondary to the vasogenic edema in the posterior portion of the white matter, and manifests as seizures, which can occur antenatally, perinatally, or postpartumly, but usually it resolves within 24 hours post-delivery. Again, delivery is the definitive management. The goals of therapy includes seizure termination, preventing recurrent seizure, and controlling the blood pressure. There's a couple of other entities just to be aware of, such as white coat hypertension and masked hypertension, which are all considered generally benign conditions, but there is an association with preeclampsia and gestational hypertension. So if you are concerned about these conditions, it's wise to monitor their blood pressures and screen for preeclampsia. Just not to forget that there are other causes of hypertension in pregnancy, not just pregnancy related. So it's other causes of secondary hypertension that should be screened for in these patients where appropriate. In terms of CKD and progression, although pregnancy is rare in CKD, it can still occur. These patients are considered very high risk, particularly in hemodialysis and PD patients. There's a very low incidence of successful pregnancy, and these patients require very good counseling regarding contraception and poor pregnancy outcomes, as well as outcomes related to the stage of CKD, which can worsen. So renal function declines proportionally to the pre-existing renal function. So if they have a creatinine under 120, it can largely remain unchanged following the pregnancy. However, patients who have creatinines of above 170, 66% experience an accelerated decline in renal function, and a third may even require dialysis. This usually happens because of the hyperfiltration injury that occurs during pregnancy and inability of the glomerulus to regulate the intraglomerular pressures. So in a normal circumstance, it should remain normal pressures, but in CKD, it increases, exacerbating the CKD risk. You also get worsening hypertension and worsening anemia, which may often require IV replacement and EPO products, which are safe in pregnancy. Blood transfusions needs to be carefully considered because it can sensitize these patients, impacting transplantation in the future. They're also at increased risk of infections, which can include asymptomatic bacteriuria, as well as access-related infections, whether it be PD access or CONCAT access. Again, these patients are at high risk of preeclampsia and should be considered for low-dose aspirin. Generally, patients are advised to delay pregnancy until receiving a kidney transplant with stable renal function. However, realistically, the waiting times for some patients to receive a transplant may be many years, and pregnancy whilst on dialysis may be the only option for some. In terms of the fetal outcomes in end-stage kidney disease, they have improved with more intense hemodialysis, but they still remain poor, including fetal loss and abortion, as well as preterm delivery. So this is two tables from the AJKD, both showing that poor maternal and fetal outcomes, as well as renal outcomes, correlate well with the pre-pregnancy CKD stage. Okay, in terms of managing these patients, hypertensive control is very important. Obviously, you have to make the changes that we discussed before with stopping ACE inhibitors and ARBs by the time of conception and avoiding adequate ultrafiltration can maintain fluid status through regular dialysis. The same antihypertensive drugs that were mentioned previously are preferred in these patients. In terms of immunosuppression drugs, so patients who've been treated for lupus, for example, you can't continue using things like cyclophosphamide, methotrexate, and rituximab, or MMF. Switches should be made to include low-dose prednisone, azathioprine, Prograf where appropriate. In terms of vitamins prenatally, water-soluble vitamins are removed on dialysis, and so the dose tends to need to be doubled. Phosphate binders should be avoided if possible because they can decrease the absorption of these vitamins. In terms of nutrition, the caloric intake increases in both HD and PD patients during pregnancy. Protein intake can also increase in HD and should increase to about 1.4 grams per day in PD patients because, as I'll explain later, we will have to increase the number of exchanges and protein loss will increase in these patients. In terms of the maternal monitoring, pregnant dialysis patients require very close follow-up, at least monthly in the first trimester, increasing to bi-monthly in the second trimester and weekly in the third trimester. There's an increased risk of cervical incompetence in hemodialysis patients, and they require monitoring of cervical length at about 18 weeks gestation. Again, monitoring for anemia and LFTs to screen for HELLP syndrome as well as advised. In terms of for the dialysis modality, dialysis is the most critical part for patients who are having advanced CKD or end-stage kidney disease. It's very important to maintain maternal hemodynamic stability during the dialysis sessions because hypotensive episodes, which are usually encountered in the last 30 minutes of hemodialysis, put the uteroplacental blood flow at risk and can result in insufficiency as well as premature contractions. Nocturnal dialysis has a higher pregnancy rate, probably related to the higher dialysis dose that's prescribed to these patients, whereas pregnancy rates in PD tend to be lower. It does have advantages over hemodialysis in the sense that there's a physiological ultrafiltration. You can still preserve residual renal function, and you avoid the need for anticoagulation during dialysis. But the disadvantages include small for gestational age compared to hemodialysis. These patients should be having a discussion to consider shifting to hemodialysis at the first trimester, but if they wish to continue PD, a hybrid therapy should be discussed where intermittent hemodialysis can be used to ensure that they reach an adequate dialysis dose. This is just a schematic showing what the hemodialysis would look like for the patient. Ultimately, they would require at least 6 days a week on the machine to target 37 hours per week. Intensive hemodialysis improves the blood chemistry, decreases inflammation and endothelial dysfunction, and remains the gold standard for pregnant dialysis women. Okay. In terms of the fertility in CKD, CKD causes dysfunction of the hypothalamus pituitary gonadal axis. So normally, pulsatile GnRH, or gonadotropin releasing hormone from the hypothalamus, is secreted in the pulsatile form, causing pulsatile luteinizing hormone and FSH from the anterior pituitary. This has end organ effects of increasing testosterone secretion in males and causing ovulation in females, as well as stimulating the ovarian follicles. In CKD, due to the changes that occur from uremia and the inflammatory milieu, you get diminished secretion in a pulsatile form. And so you get diminished testosterone production and low libido in males, as well as impaired ovulation in females. As kidney function declines, females may experience amenorrhea towards the end stage and ovulation, as well as earlier onset menopause in CKD. The mean age of menopause is around 47 years old in CKD compared to the general population of 51 years. Post-transplant, these changes can improve as early as 3 weeks, but generally by 6 months post-transplant, there is resolution to the hypothalamic pituitary gonadal axis. Just keep in mind that patients who are at the end of their reproductive years may not experience full return to fertility. So these patients who do fall pregnant are considered high risk pregnancies because of the risks associated with the fetus, the maternal risks, and the graft risks. KDIGO advises delaying pregnancy until the first year post-transplant. European best practice guidelines advise delaying until the second year. It's essential to counsel these patients on safe and effective contraception preceding transplant. The birth rate, as you can see, is a lot better compared to hemodialysis. In terms of predictors of good outcome, it's the ones on this slide. So younger patients who have better renal function pre-pregnancy with no history of rejection, unstable and low doses of immunosuppression, and patients who delayed pregnancy for the first year. In terms of the maternal outcomes, again, they're at high risk of hypertensive disorders, including preeclampsia, as well as rejection. So normally the allograft should accommodate an increase, should reaccommodate with a 30 to 50% increase in creatinine clearance in the first and second trimester. If you don't see this drop in creatinine, or there's an increase in creatinine, various considerations such as graft dysfunction, onset of preeclampsia, rejection, drug toxicity, volume depletion, or obstruction need to be considered. Graft outcomes are fairly good. Even if there is a decline in GFR in pregnancy, there is no increased risk of long-term graft loss compared to non-pregnant transplant patients. These are the fetal outcomes. So in transplant patients, preterm delivery is increased with a mean gestational age of about 34 weeks with low birth weight of about 2.4 kilos. They're also at risk of congenital abnormalities, including teratogenic drugs due to teratogenic drug exposure like CellCept. In terms of the long-term outcomes for these children, growth appears to be similar to the general population after the first year of age, with no long-term differences in growth, neurocognitive function, or vaccine and antibody response compared to the general population. Care for these patients is quite complex and requires good antenatal care, which should be started at the diagnosis of pregnancy, involving an MDT team again. Screen these patients for preeclampsia, gestational diabetes, particularly if they're on Prograf or high doses of steroids. They're also at risk of intrauterine growth restriction and preterm labor. In terms of the maternal health, you need to discuss factors associated with good outcomes, such as delaying the pregnancy, teratogenic drugs which need to be changed, such as CellCept, which should be considered to be swapped out for azathioprine if possible, as well as vaccine considerations. So patients should be fully vaccinated pre-transplant and receive an annual influenza vaccine during transplant and before pregnancy if possible. Drug level monitoring has to be done very closely throughout pregnancy because of changes in albumin and protein plasma binding, which is decreased, increasing the clearance of drugs like tacrolimus and cyclosporin. So the doses may need to be increased. And then supplementation such as iron and folic acid also needs to be continued. This is a table from a recent article in CMJAH focusing on pregnancy and transplant patients. And the drugs that are considered safe and low risk are azathioprine, cyclosporin, and tacrolimus. Although not teratogenic, they do increase the risk of hypertension and preeclampsia, and they do require dose adjusting during pregnancy. Prednisone also increases the risk of gestational diabetes and hypertension, so ideally patients should be on a low dose if possible. Contraindicated would be drugs like MMF or Salsept and mycophenolic acid, which cause developmental toxicity and malformations in animals. It should be stopped at least 6 weeks before conception. It's not enough safety data for other immunosuppressive drugs, so they're not advised. In the first trimester, an obstetric scan at the first visit is recommended to confirm an intrauterine pregnancy, date the pregnancy. Normal booking bloods, like you would do in every other pregnancy, should be done. Screening for chromosomal abnormalities such as Down syndrome need to be interpreted carefully, as levels such as PAPA or pregnancy-associated plasma protein are increased in transplant patients and can lead to false positive Down syndrome screening. Consider these patients high risk for preeclampsia, and again, prescribe aspirin if not contraindicated. Screen them for gestational diabetes at 12 weeks and follow them closely for the first trimester, at least every 4 weeks. In the second trimester, follow-up increases to at least every 2 weeks and eventually every week until delivery in the third trimester. Okay. In terms of labor and delivery, again, involve a multidisciplinary team. The mode of delivery is determined by obstetric indications like in other pregnancies. So a cesarean is not mandatory. There is a risk of renal artery injury during Caesar. Patients who have been on long-term steroids should be considered for stress steroids as well. And just be aware of possible complications such as anemia that can occur in these patients during the delivery. In postpartum period, the AAP and the AST, the American Society of Transplant, both recommend breastfeeding. So drug considerations need to be applied. So azathioprine, prednisone, and tacrolimus are considered safe. Mycophenolic acid have to be stopped because it is found in breast milk. In terms of contraception in pregnancy, in CKD, so there's an increased prevalence of unplanned pregnancies in post-transplant population, particularly among adolescents, which have a high risk of unplanned pregnancies in general. So contraception needs to be seriously discussed with these patients. There's a high rate of fetal anomalies and poor fetal outcomes, as well as poor maternal outcomes in all of these patients, and a serious risk of CKD progression. So ideally, it should take place before transplantation in patients who are on the transplant list. Contraceptive methods and their reproductive options need to be discussed, as well as medications that are going to be changed to minimize effects to the fetus, mother, and graft. In patients who are on Salsept for whatever reason, it's advised to use at least 2 reliable methods, one of which would be consistent condom use. This is a table from the CJSN, which is just showing the various options for contraception and their failure rates. The intrauterine devices are highly effective, with condoms and barrier methods being the least effective, which should be in combination with another method. Okay. So in terms of contraception in kidney transplant patients, it's divided between patients with stable graft function or patients with complicated graft function. So patients with complicated graft function include previous rejection or chronic graft failure. And these patients should be avoiding any estrogen-containing drugs because of the risk of worsening proteinuria and hypertension. IUDs are still considered safe and are probably the best option in these patients. So in conclusion, pregnancy undergoes substantial physiological changes, which we all need to be aware of. For example, a normal creatinine is not really a normal creatinine in pregnancy. Pre-existing renal disease may worsen and lead to poor outcomes, as well as preeclampsia. CKD can progress to end-stage renal disease like it did in our patient. So counseling is essential to ensure the best outcome, and always involve, if possible, a multidisciplinary team, including an obstetric physician and nephrologist. These are my references.